Okay, we'll just go ahead and get started, and as people join, they can kind of pick up where we're at. So my name's Katie. I'm the Program Evaluation Specialist for Medic. For those who don't know me, Megan is out this week, so you guys are stuck with me for this presentation. This is kind of part 2 for our head injury roundtable series here. We did the adult head injury roundtable a couple weeks ago, and that went pretty well. So the focus today is on our low and intermediate risk minor head injury measures for our pediatric population. So just a reminder, you guys all had to acknowledge a confidentiality statement signing up for the webinar today. We are sharing just a couple of slides of unblinded data for 2 of our presenters. So just keep that in mind. We are recording the meeting with the hopes of being able to publish some of this on our website, some of the helpful information that we find today. And then also just a reminder of who's here. So the majority of us from the coordinating center are here. We've got a lot of abstractors on the call. We've got our clinical champions on the call. We've got some interested others, which is awesome. So that's kind of who our audience is today. Just a reminder of our goals. So again, this is our all in for head injury year. We're looking to walk away from today with some actionable items. Again, even if it's just finding somebody to connect with that, had some really good information for you to connect with outside of here. We want you to bring forth any questions you have, good questions, bad questions. There's no such thing, right? We want kind of anything that you're working on that you've faced challenges with, bring it up. Hopefully we can help you work through some of those things. So I will turn it over to Michelle Nypaver to kind of go through a couple other things.
Everybody, can everybody hear me? Okay, welcome. It's April, late April, and it's snowing. I know everybody's really excited about that. But thanks for tuning in today. We're gonna kind of refocus our efforts on the pediatric minor head injury, all in for head injury year. And so I wanted to give a little bit of context on where we are at and kind of review some of the main points of this work. So remember that, our whole goal this year is for everybody to kind of move up in terms of our practice surrounding head injury in general, and specifically with intermediate head injury in the pediatric care as defined by the PCARN head injury rules. From the big picture down, remember, emergency departments are the places where 85% of children get their care in the general community rather than children's hospitals. So everybody in Medic who are working on these measures are largely from mixed population sites, with the exception of a couple of children's hospitals. So our collective goal is to kind of shorten the time course between what we know and works best and those centers that have a lot of kids and those community centers that are already doing fabulous on this, and try to try to create a space in this call to be able to share those learning lessons and try to all improve quicker. So basically, there is a difference. If you remember the pediatric head injury rules as defined by Nate Cooperman in the original PCARN study, they broke kids down into low risk head injuries and intermediate risk. And basically the intermediate risk were those patients, those children, again, broken down by age, less than 2, and then the greater than 2 to 17-year-old groups, and weren't quite low risk, but didn't meet the absolute highest risk for head injuries. So this is a little bit more of a nebulous space, but nevertheless, we are trying to drive that number down because there still is a lot of ambiguity in the space that we can still try to improve upon. So I wanted to just give everybody that sort of landscape of where we are in the world and why we're trying to do it, because they still contain a lot of CT scans that we know there's some low-hanging fruit there. Next slide. So in terms of how we define it, and remember, this is on the website too, in the flow charts, we define this measure as those children who meet the criteria for intermediate risk minor head injuries, those children who had a CT over the total intermediate head risk group. And so remember, we have denominator exclusions, right? And those are pretty obvious. Those kids who don't meet the ruled definitions, that is those who have a GCS of less than 14, that the injury is greater than 24 hours out, that there is a description in the documentation of an actual penetrating injury, anything that was a trauma activation, if a patient was pregnant, anybody who has a bleeding disorder, who's on coagulation medications, as well as those kids who we think might have had this injury that was potentially related to non-accidental trauma, because our hand may be pushed there to do some imaging that we normally wouldn't do. And those kids who had potentially have a VP shunt or some sort of intracranial mass or tumor. So in those kids who have a history of some sort of cognitive delay, for which your clinical criteria and even the PCARN criteria may be a little bit high, difficult. So we're going to just show you the actual flow diagrams next to kind of show you how we parse out how we count these cases. And we kind of put this into an easier reading PowerPoint slide for all of us. So remember, in kids less than 2 years old, and the kids over 2 years old, the criteria to get in is that you have to have a GCS of 14 or above. And so another little just point to abstractors and clinical champions on the call, that documentation of GCS is really super important. And in kids less than 2 years, the high risk group is, a little bit different in that signs, whereas less than 2 have a palpable skull fracture, whereas in kids older than 2, it's signs of a basilar skull fracture. But both have to have criteria for agitation, somnolence, slow responsive repetitive questioning. The intermediate group, which is the group we're interested in this call, is really that they don't have any of the high risk factors. And then in kids less than 2, largely who may have difficulty communicating because they're pre-verbal or have limited verbal skills, you're looking for scalp hematoma, excluding a frontal scalp hematoma, loss of consciousness, or not acting right for parent. As providers, we always hear that, she doesn't look that bad, but she's just not acting normally, or history of a severe mechanism of injury. So notice that there is a little difference for kids less than 2, the fall height is 3 feet, whereas in kids older than 2, the fall height is 5 feet. And then you have the typical, ejection, rollover, fatality, bike versus pedestrian versus vehicle versus without a helmet or struck by a high impact object. So this is where we're at. Last year and the years prior, we were working on low risk CTUs, and now we're in this yellow area in their intermediate risk. I'm going to stop there for just a second to make sure if anyone has any questions about the focus of this particular year's work. So I'm going to let Katie take over here and talk a little bit about our current state of performance.
So these next graphs you're about to see, this is the last 12 months of performance up to when the data registry kind of paused with the transition to Arbor research. So you can see here, this is the statistics for the overuse. In particular, today we're going to focus on more the intermediate risk group. So kind of one thing I wanted to point out, so our current collaborative wide target is less than 15%. Sorry, so the collaborative wide target is less than 18%. Your site level target for this year is less than 15%. So kind of what I wanted to point out here is that we've got quite a few sites along the cusp of this, but we definitely have some work to do for this year, which is again why we think that going over this now is so important, because we do still have some room to improve here, and we need to get kind of more to that yellow area there in order to meet our VBR target for this year. So that's kind of what we're looking at. And the first thing we're going to do,